Good afternoon. Thank you, Joe. I appreciate the introduction and all of the, excuse me, and all of the helpful information. My name is Dr. Piper Meyer-Kalos, and I'm a clinical psychologist. I'm the executive director of the Minnesota Center for Chemical and Mental Health, and I really appreciate having this time today with you guys to talk a little bit about some work I've been doing. For about the past 8 years, I've been working with first episode psychosis teams across the U.S., and I'm hoping today to share some of the information that I've learned across the way and provide some information for people that are interested in why are we talking about this now? Why is this coming up so much more now? What do we know that's different from the standard treatment that's out there? What's the evidence to support it? And finally, I'll provide a little bit of information about if you are seeing somebody who has a first episode of psychosis, there's some helpful tips that you might be able to use in your own practice, and so that's what I'll end it with. I would like to say before I start that there are many people that have been involved in this process, but I would particularly like to thank three of my colleagues who've done a lot of this training with me. Shirley Glenn, Susan Gingrich, and Delbert Robinson, who've been involved in the Navigate trainings across the country with me. So let me first get started. I'd like to just start out and just talk about how common this is. You can see here from the bullets that a really large number of young adults experience an episode of psychosis every year, and in fact every day. This is something that people have come up from time to time, and we've started paying attention because of the implications for treatment and a person's trajectory over the course of their life. What is also interesting is some of the research has recently said, when they looked in the US, that the time that somebody experiences some psychosis symptoms for the first time until the time they're actually seen for mental health treatment in like a mental health center could be more than 2 years. So that's a really long time. That's something that we call the duration of untreated psychosis. And that's important because there's study after study after study that's actually found the longer the time between when somebody first experiences their symptoms until they get treatment leads to worse outcomes. So one of the big pushes behind this emphasis and behind these treatments is to really reduce the amount of time, wait time, that someone experiences so that we can really catch people as early as possible and give them the best possible chance for recovery. The last bullet there talks about what happens when somebody experiences psychosis. We know that 3 times as many young adults who experience psychosis will drop out of school compared to their peers. So we know that this is a population that's extremely at high risk for getting on that normal trajectory around work and school that happens around this age. In addition, we know that treatment works. We know that 77% of people experiencing first episode psychosis will actually have a remission of their symptoms with medication. We know that people can get better, that people can feel better. The tricky part of this is that only 2/3, or actually 2/3 of individuals will experience only a limited functional recovery. So that means that even though people might experience some reductions in their symptoms, it doesn't mean that they're all getting back to work and school and getting on that normal trajectory that we would expect young people to be doing. So with that information put together across the world, and now in fact in the US, we've placed a bigger emphasis on getting treatment out there that works and getting it out sooner. So one of the reasons that you might have heard more about this is in 2014, the federal government actually increased the block grants that every state in the country gets. So every state in the country gets something called a mental health block grant. And this is money that's provided to create and sustain mental health services in the state. It's not a lot of money, but what happened in 2014 is they actually added 5% to every state's budget and said that it had to be dedicated to setting up evidence-based programs for first episode psychosis. And that meant that every state, including Minnesota, got money to start setting up first episode psychosis programs. What they did in addition is they utilized some guidelines from some studies that had been done in the US around what kind of treatment works within our system. And why that's important is much of the research that's been done outside of the US has been done in countries that have a single payer health system. And we actually have a multi-payer health system, meaning we have lots of different insurance and payers for health care. And it was really important that we find out more information about how this kind of a treatment could work in the US in our multi-payer system before we rolled this out. And so that's in fact what they did, and that's why this was so important. That this came out of some research I'm going to talk about here shortly to kind of tell you what we found out and what works. So the combination of setting up the increase in the block grant and the research that supports what works in the US have led to this emphasis on treatment for first episode psychosis. One additional note is that since it was created, since the 5% set aside was created, Congress actually doubled that. So a year or 2 years later, they actually went from 5% to 10%. So now every state receives 10% over their block grant money to support treatment for first episode psychosis. So this is the model that the government talks about and SAMHSA talks about that is helpful for persons with first episode psychosis, and they call it coordinated specialty care. And what that means is that the person is in the middle that you can see there, and there's a range of different treatments that are offered at the same time that are specifically designed for this population and for somebody early in their treatment. So it includes medication and primary care, it includes psychotherapy, it includes family education and support, it includes supported employment and education, and it includes case management. Those are the key components that SAMHSA has said need to be elements of a program that's set up. So just to give you a little context of what the landscape looks like, these were the states that in 2008 actually had a program for first episode psychosis or early psychosis. And you can see here, there's only 2 highlighted. In 2016, that's gotten a lot bigger. And that plays into the fact that the government's really supporting the increase in these programs. And so right now, as of 2016, there were 32 states that had programs with over 120 clinics. In 2017, that number is growing even faster. So I want to step back for a minute just to talk a little bit more about what psychosis is, so that you have an idea, what am I looking for? What would this look like if I were to meet with somebody? What would I be looking for? So start off and thinking about what do we mean when we say psychosis? So one definition of psychosis is often a loss of contact with reality. And this can include different kinds of symptoms. So it could include things like a thought disorder. It could include hallucinations or delusions or odd speech. And oftentimes this can include some unusual or bizarre behavior that's included with it. This is coupled with impairments or difficulties in social interactions and carrying out daily life activities, including work or school. So those are the kind of main things that we're talking about when we think about psychosis. Some people have defined this as it feels like they're dreaming while they're awake. We also know that it's pretty common. If you look across the lifetime, about 3 in every 100 people will actually report some experiences of psychosis over the course of their lifetime. There are lots of different things that actually can cause psychosis. Here's a list that includes things like drugs or alcohol, stress, sleep deprivation, and the last one there includes mental illness. So just because someone's experiencing psychosis doesn't always mean that it's related to mental illness. There are lots of different things that can cause it. And sometimes it actually goes away on its own, whereas oftentimes, many other times, it continues. And so those are things that are important to be aware of, that there are different things that actually can cause it. When we're talking about coordinated specialty care, we're primarily talking about treating psychosis that's related to a diagnosis of schizophrenia or mental illness. So specifically, in these coordinated specialty care programs, they're focused on people with schizophrenia, schizoaffective disorder, or schizophreniform, which is just experiencing schizophrenia less than 6 months. So the symptoms of schizophrenia include what we call positive symptoms, or something in addition to your normal experience, negative symptoms, which is kind of a reduction of what your normal experience should be, and cognitive difficulties. So you'll see here the symptoms that are highlighted in blue are positive symptoms. So these are some of the symptoms of psychosis that we were talking about that include delusions, hallucinations, disorganized speech, and disorganized or catatonic behavior. Typically, medications are more helpful in treating those positive symptoms. Those are typically the ones that what we think of as remitting a lot quicker and sooner than the negative or the cognitive difficulties. Negative symptoms include things like a lack of interest, a loss of energy, a lack of initiative, or a sense of pleasure in things. And these are, as I said, much difficult to treat with medications. The cognitive difficulties include problems with focus, attention, memory, and executive functioning. So how do we know that psychosis might be coming up, or that someone might notice it? These are the most common signs of emerging psychosis. And so they include things like a rapid drop in school, work, or family life. Other things might include spending a lot of time alone, especially in the person's room, doing or saying things that are strange, bizarre, depression, irritability, having problems sleeping. There's one big problem with these common signs. The range of people that experience first episode psychosis goes anywhere from age 15 all the way up to 40. However, it's typically occurring in people who are of younger age, typically maybe that age from 17 or 18 into the mid-20s. When you think about that age, sometimes these kinds of symptoms are common for someone in that life stage. So that's an important thing to kind of keep in mind, is that just because you notice these kinds of things doesn't always mean it's psychosis, but these are good things for you to check out. I've got another list here of additional signs. Again, some of these things you might expect with somebody of a younger age, and some stand out as something you want to ask a lot more about. And these can include things like social withdrawal, oversleeping or insomnia, a decline in personal hygiene, a flat or expressionless gaze, inability to cry or express joy. So these are just a good list for you to be aware of if you're wondering, could this be psychosis? So another important thing to consider when you're thinking about is this person with first episode psychosis is where they might show up. If we look at the research that's been done in the United States to date, the place where we find people the most often is referrals from an inpatient unit. So these are actually when somebody has already been hospitalized. And that leads us to really, it helps us make sense of why that duration of untreated psychosis might be so large, is that we're actually not capturing people as soon as possible. We really are working hard to try to expand ways to reach out to people to get more information out there about how to recognize this, and where they can go for help as soon as possible. Other places that people might show up with a first episode of psychosis include emergency rooms, crisis services. It may be referrals or connections with religious leaders in their congregations, primary care, schools, also criminal justice kinds of contexts sometimes show up, and substance use programs. So the typical interventions for psychosis are going to be very similar to what we were referring to for coordinated specialty care. They include medication, sometimes short-term hospitalizations, psychotherapy, case management, vocational counseling, and family counseling. And this is going to be helpful when I talk about what the research in the U.S. found and how that's really informed the models that are specifically being used in the U.S. So we're really excited about the development of this coordinated specialty care model, and we really think that the opportunity to provide this care, this effective care, early as possible can help people get to their recovery sooner and live more full, rewarding lives. What I'm going to talk about is the research and the evidence that supports this model within the U.S. that we call Navigate, and the Navigate programs that we actually have here in Minnesota. So let me start off and give you a little bit of background about RAISE. So RAISE stands for Recovery After an Initial Schizophrenia Episode. And RAISE was the program that came out of the National Institute of Mental Health in 2009. They essentially said that outside of the U.S., they're doing a lot of work and are pretty successful with helping people with first episode psychosis. But as we mentioned, those programs are often within single-payer health systems. So the RAISE initiative was launched to really figure out what is a method of treatment that could be done within the U.S. system, within the existing U.S. system, to treat first episode psychosis. There were actually two programs that were funded. One of them was called the Connections Program, and it's now called On Track USA. It was mostly done in the state of New York and the state of Maryland. And the second one was called the Early Treatment Program, or RAISE ETP, and it's now called Navigate. And I'm going to be talking more specifically about Navigate because Navigate was the program that involved a randomized controlled trial that has really led to the strongest evidence to support treatment for first episode psychosis in the U.S. So when I say Navigate, I'm going to explain a little bit about the different interventions that are included in Navigate. They include a personalized medication management approach. This is based on an algorithm that has been developed with evidence for medications that have specifically been shown to work for persons with first episode psychosis. So there's a list of medications that are on that list that actually have evidence, and then there's steps of different things that you can do to really address the symptoms in a way that's going to maximize the treatment effectiveness and minimize the side effects. Because the other thing that we know about medications for persons with first episode psychosis is that people are really, really prone to side effects, And so in the program, we do something called we watch them like a hawk, so that we can better monitor those side effects. Because we know that if as soon as a young person starts experiencing these, they're more at a higher risk of stopping their medication. So we work really hard in the medication management program to use the lowest effective dose and to monitor those side effects. The second component is family education. And this one is really important because we want to get as many family members and supportive persons involved and provide them as much education as possible as early as possible. Because one of the things that we know is that treatment and treatment providers may come and go, but the family is going to be there. And we want to shore up the family as strong as possible so that they can help their loved one get back to recovery and get back to their life. The next one on there is supported employment and education. And this really speaks to one of the elements that I was talking about earlier, where even though almost 80% of people experience a reduction in their symptoms with treatment, only approximately 2/3 experience a very limited return to things like work and school. So we knew that an essential piece of an intervention for first episode psychosis needed to be supports to help people get back to work and school. And that's exactly what SEE does. The SEE specialist on the Navigate team meets with people individually in the community to help them develop work and school goals and to take steps towards those goals. And this includes reaching out to schools, colleges, and universities, as well as potential employers. And this is one of the most popular elements, I would say, for engagement in treatment for these young people. The next bullet is called individual resiliency training. And this is the component that I was most strongly involved in developing. And this is the psychotherapy component. And individual resiliency training, or IRT, is focused on helping people learn self-management strategies and skills, learn more information about their illness, so providing them psychoeducation, and learn some specific strategies and get some help in making steps towards their goal. So it combines all of these things together. It's probably the biggest manual of all the interventions. However, it offers clinicians who use the intervention a wide array of materials to address things from healthy eating and exercise to social supports, enhancing social supports, and having fun and developing relationships, to coping strategies, and including some cognitive behavioral interventions to address some of the negative feelings that people are experiencing. The main focus in IRT is around goals. So in every session in IRT, it's always, the primary focus is always on helping a person take a step towards their goal. And so that's typically happens weekly for a while, especially in the first 6 months. The last bullet is some additional services that are provided on the team. Some of these we combined in the original research project, but we really learned a lot about the importance of things like case management and peer specialist services. Some teams have had a combined position where someone like the IRT clinician is also providing case management. Other teams have included a separate person to help with case management because there's an overwhelming need that people present with. There are also many teams that are including peer support specialist services. We really feel like this is an important piece of a Navigate team. And we're still continuing to learn about how best to utilize the peer specialist on the team so that people are getting exposed to that as soon as possible and getting support from someone with lived experience. it's not only these 4 or 5 specialties on the team, but it's how the team works together, and that's another part that makes Navigate so special. At the beginning of treatment, everybody meets together, and so we try to include family members as well as the clients and all of the team members to get everybody on the same page to make sure that what the client wants is front and center, and that is part of going to be the focus of treatment. The other thing is that the team really works together to make sure that the person is receiving as many benefits as possible from each of the interventions. There's not a requirement that someone has to participate in all of the interventions when they're enrolled in treatment. Certain teams have certain different requirements. We typically recommend that they're participating actively in at least one of those treatments that we listed. But behind the scenes, the team is always working together to help introduce and engage the person in as many services as would be beneficial. The third bullet there talks about how the team members meet together. There's regular meetings where all of the team members get together and can share information. This is also where they can share how to continue to engage the person, and maybe if someone is feeling stuck, they can actually join together to increase that engagement, which leads to how we can what we call piggyback appointments, so that it may be that the person is really interested in getting a job or going back to school, but there have been some things that have been popping up when the SEE specialist is meeting with them. The SEE specialist, with the person's permission, can invite the IRT clinician to join them for a session. This really allows for continued collaboration and building engagement, so the IRT specialist could offer additional suggestions and strategies and information that might help somebody who's struggling with coping with some symptoms, particularly around things like going on an interview or joining in some discussion in a classroom. These are ways that the team members actually can really work together very strongly so that we support the person and maximize engagement. All right, so I'm going to talk, now that you know a little bit about what Navigate is, I'm going to talk a little bit about what the evidence is behind Navigate. So the RAISE ETP program was done in 34 sites across the U.S. There were 17 that were randomized to Navigate and 17 that remained what we called community care or control sites. This is really an interesting distinction because of, rather than randomizing within the site, so that in a site half the people got Navigate and half of them got the control, we actually randomized by site. So the entire site was a Navigate site, or the entire site was a community care site. When people joined the study, they were asked to participate in the program and the assessments for at least 2 years. Since then, we've continued to follow people, and the 5-year assessment since the end of the project has just started to wrap up. We were aiming for a sample size of 400, and we got to 404. So we were looking for around 10 to 20 people enrolled at each of the sites. The age group here that we used in RAISE ETP was ages 16 to 40, and they had to have one of these diagnoses that were done over video. So they were actually blinded raters that did this over video conference, and they confirmed one of these different diagnoses: schizophreniform, schizophrenia, schizoaffective disorder, psychotic disorder, NOS, or brief psychotic disorder. The last criteria said that there had to be evidence that there was less than 6 months of lifetime treatment with an antipsychotic medication. This was really to ensure that we were getting people as early as possible with the least amount of exposure to mental health treatment in their past. So this was really, are we getting that population so that we really know that this treatment is going to be effective with people when they first start experiencing symptoms? Here's a map of the different treatment sites, and these include both the Navigate and control sites. What I think it's important to mention here is we did try to really get a wide array of different sites, and they included very urban sites, some suburban sites, and some very, very rural sites. So what did we find? So compared to normal control usual care, the people that received Navigate were more likely to stay in treatment, had greater reductions in both their symptoms of psychosis and symptoms of depression. They had greater improvements in quality of life, and they had greater rates of participation in work or school. So this evidence really suggests that if someone is getting treatment from a Navigate team, they have a greater likelihood of having these better outcomes. And one of the things that was really unique about the RAISE ETP study was the focus on quality of life. Rather than having symptoms be the primary measure, the primary evaluation and assessment measure, quality of life was targeted. And this was really to show how can Navigate really make a bigger, longer lasting effect on things. And so it's not just that first part that we were talking about earlier, where people found that their symptoms got better. It was really about improving those things like their social relationships, work and school, and participating in those things that lead people to feel like they have greater meaning and purpose in their life. So as a result, I always like to mention, it was a really big deal when the results came out. And this is in partly in response to what we talked about with the federal government's response, is that when these results came out, the evidence was actually featured in both the Washington Post and the New York Times. And so this is one of those things that this is why you're hearing about this more possibly. This is why there's been much more of a focus on this. And this is really landmark in that it was one of the first, and it is the largest randomized study that's been done for persons with first episode psychosis. So these results had longer lasting, larger impact. So just to give you a little bit of context, I know that I showed you the map earlier, but this tells you a little bit about where Navigate is. When states use a coordinated specialty care program, they do have some choices. It has to include those certain elements, but they can choose different programs. For Navigate, here are the states and even another country that are now using Navigate in the US and outside the US. And so you can see here it's about 16 different states with lots of different programs. And that's really important because Minnesota is included in that. We actually have 3 teams, Navigate teams in Minnesota. 2 of them are at the University of Minnesota in mHealth, and one of them is at HCMC, and it's called the HOPE program. I've included the links for information about both of the programs, and included there is information about how to refer or actually how to contact them to get more information about these programs. So we're really excited to have these Navigate teams here in Minnesota. So I want to finish things off and talk a little bit about what you can do if you start working with somebody who is early in the stages of their treatment, who you think is probably related to their first episode of psychosis, and some practical things that actually can make a big difference in how you work with that person. One of the first things to recognize is the importance of the language that you use to talk about their experience and what happened. A very simple thing that clinicians will often do is change the way they talk about what happened. Rather than talking about what symptoms did the person have, asking them about their recent experience of things and what was difficult about it and what came up about that experience. Help me to understand what happened to you. Because you want to really try to understand, how does this person make sense of this? What is going on? How have they talked about or thought about what happened to them? What do they use to explain it? So a very simple way to focus from talking about symptoms, which can be very deficit-based, to talking about the person's experience, which is much more inclusive. Another way that you can really make an impact in how you talk about things is to focus on what the person wants and what their goal is. What is important to that person? If they think about living their life and living a happy, healthy life, or being well, or getting their life back on track, what kinds of things are important to them? What kinds of things come up? A focus on the goal really helps the person connect with you and build that engagement. Engagement with persons with first episode psychosis can be very challenging. There's a lot of scary things about treatment, about the symptoms that they're experiencing, and you connecting with them about what's important to them and continuing to come back to that and help them take steps towards that can really enhance your engagement. The third bullet really talks about, how do they make sense of what happened? There are many people that might come in to see you and not think that this is schizophrenia. In fact, most of them probably won't. It's really important for us to understand, how do they make sense of that? This is particularly important because many times the stigma that's associated with mental illness, and particularly schizophrenia, is pretty strong. And it feeds into a lot of the reasons why somebody might have an alternate explanation of why this happened to them. So there are many things that come up where somebody might say, that was just a one-time thing. That won't ever happen to me again. It was just because I didn't get enough sleep. It was just because I was stressed out because of my finals. Exploring that more with the person, helping to understand why it's important that they have that or hold on to that alternate explanation, can really be helpful, and again, really enhance the engagement that you have with that person. The next part that's really going to be helpful is not giving up on providing information about the symptoms, about diagnosis, about the stress vulnerability model, even if they are saying this was a one-time thing, even if they're saying, that's not me, I don't have that illness. There are many ways that you can still provide information to that person, even if they don't believe they have that illness. These include asking about what their experience was if they had a hospitalization. So referencing that time point, what kinds of things did people talk about with them? What kinds of clinical terms did they use while they were there? Would it be helpful to get some more information about some of the things that they heard when they were in the hospital or in the ER? These are ways to provide that information and to really inform a person, but not yet assume that they have to agree with the diagnosis to do it. Another way that you can provide that information about the illness is to talk about people that they may have known who've had some of these kinds of experience, and would they be willing to talk with you about some of those things, just to explore what do they mean when we say hallucinations or delusions or thought disorder. There are lots of different ways to approach this, but this is a way to get that information across in a way that the person doesn't feel like they have to fully accept or be at that place where they're not really ready to be in their recovery. But we still want to be able to offer them some information so that we can increase their awareness and make sure that they can make the best, most informed decision possible. The last one on here is really around being patient. There's a lot that's really new here. There's a lot that's really scary for some people here. And just being patient and meeting the person where they're at can really, really help you here. So these are really centered around when you're first meeting with that person and you're really trying to engage them. There's also some helpful strategies in thinking about the families and the person's first experiences with mental health services. It's really a new experience for me when I started doing this work to think back about what might it be like if you were walking into your mental health center for the first time. What might it be like if you got hospitalized and you were on a locked unit for the first time? There are a lot of things that you may not really understand how they work. You may not even understand what you're supposed to do or say in therapy for the first time. Your family may not understand what happens in family education or how the family should be involved. So there's lots to just be aware of that really can inform how the person is doing, how they're engaging, how their family members are engaging, and really being sensitive and understanding about a person's experience as they're acclimating and getting used to what do these services look like, what are the expectations that people have for me, what expectations should I have for myself, and just that awareness of what that's like for the first time. Another thing is meeting them where they're at. One of the most helpful things is that this is very different than having people come to our office. Many times we are really working to seek people out. We talked about the different places that you might find people with first episode psychosis. The Navigate teams do a lot of work around recruitment. They're always out in the community trying to provide more information about what first episode psychosis is, what the Navigate teams do, how to contact them, what kinds of things that people should be looking for. And so this is very different because we're trying to educate people who wouldn't necessarily show up on our doorstep. And that's part of the reason why we have to, when people come into treatment, meet them where they're at. So this sometimes means that we're actually meeting with them in the community rather than expecting them to always come into the office. But it also means that we really mentally meet them where they're at and their understanding of what happened. As we talked about, there's lots of alternative explanations that people might have for why this happened to them. And we have to be willing to meet them where they're at and understand that they might have some of these alternative explanations. Lastly, I think understanding what the role of self-stigma might be. There are oftentimes many reasons that people hold on to these alternative explanations. Feeding into the stigma that's associated with mental illness, and particularly schizophrenia, there are people that believe that if I have schizophrenia, I will never be successful. I will never hold a job. I will never do all of these things. We know these things aren't true, but for them, it's more important to hold on to the alternate explanation of why it happened than to believe these other things might be true. So we as the practitioners need to understand that sometimes there's a reason why people have some of these beliefs and hold on to really tightly sometimes some of these beliefs, these alternate explanations for why things happened. Another helpful strategy is, here is our opportunity to set the stage, to really bring into the fold family members and supportive persons as much as possible and as soon as possible. So think back for some of your clients who've been involved in treatment for a long time, and the supports that they have around them and sometimes don't have them around them. There is an opportunity, because of the young age that many people experience this for the first time, where they're still heavily involved with their family units. We have an opportunity to really engage these family members and support persons from the get-go, to provide them education right away, to really work with them on engagement and helping their loved one engage in treatment so that they can be on their path to recovery. Included in this, with the Navigate manual for family education, is we can work with the family around problem solving and communication. Two simpler things sometimes that we at least have some steps and some skills that we can work on with people to help them with this, to really build up, to kind of shore up the family for the long haul. I always like to remember that treatment and providers may come and go with somebody over time, but their family members, their support persons, they're going to be there for the long haul. So we want to make sure that we do everything possible when somebody comes in for treatment for the first time to really fully engage those supports as much as possible. Okay. I want to say before I get to the summary, and I do have a few minutes for questions, I wanted to say that because the RAISE ETP Navigate study was a federally funded study, all of the manuals that we used in Navigate are online for free. If you go to navigateconsultants.org, you will be able to log on there and you will be able to see two different things. You'll be able to see PDF copies of all of the manuals. And there's manuals on there for the team members, for the prescribers, for the family education clinicians, for the program directors, and for the supported employment education specialists, and for the individual resiliency trainers. There's manuals for each of those. They are available for download for free, and anybody can use them. The other thing that's on that website is videos. We have some training videos specifically designed around training clinicians in individual resiliency training. Those are also available on the website for free. Those are two really, really great resources that were paid for by your federal dollars, and so I encourage you to check that out. So I'm going to wrap up a little bit, and then I've got some time for questions if anybody has questions. So I'm really excited to be able to bring Navigate to Minnesota. We have some of the best teams in the country, and they're working really hard. Please check out their websites. They've got some good information, and they've got those contact numbers for you. We're really excited that this is blossoming across the state. It's really heartwarming to see how many teams are developing across the country, and how much this means that we can work to reduce that duration of untreated psychosis that I talked about at the beginning of this talk. That instead of waiting over 2 years for somebody to get help and to get support and to work on their recovery, that they can do it in a whole lot less time. So I'm really excited that so many of you were able to attend this talk today. I hope it was helpful to learn a little bit more about what first episode psychosis is, why we're talking about it, and what the treatment looks like. So I've got some time for questions. Joe, do you have any questions there?
Yes, we do, Piper. Christine asks, why do Do we know why 2/3 of individuals do not reach functional recovery? Is it a lack of programming or just the course of the disorder?
I don't think we have all the answers for that yet. It does seem like that the programming that oftentimes we have that we know is what we call evidence-based isn't always accessible right away. So somebody walking in doesn't always have access to all of these treatments at the same time. And that lack of access can oftentimes lead to difficulty with that functional recovery. I also think we're still figuring that part out. It's trickier. We're learning more about what to do to help people get back to work and school and to get back to their friends and their families, to be more social, but I think we're still learning. So I think it's a little bit of both.
Perfect, thank you. Amy would like to know, how is the person referred to the program?
So the easiest way to do a referral is to go to those two websites that I had listed in the PowerPoint. And if you click on those, there'll be numbers that you can contact both of the Navigate teams and talk to somebody and get screened. So that is probably the easiest way to go, is to actually, you can call as a practitioner, you can call as a family member, or you can call as a person with that experience, and they will walk you through that screening process.
Thank you. Trevor asks, can you summarize any key differences between Navigate and the ACT model for individuals experiencing FEP?
That is a really good question. I'm really glad you asked it, because you are correct. There are some similarities, but there's also some big differences. Let's talk about the things that are kind of similar. So first of all, ACT, similar to Navigate, is a team-based model. So they both are really meant to have all of these different services provided to the person and being able to access. Some of the biggest differences come in where in the ACT model, there's a different focus where everybody gets what we call cross-training. So there's an expectation that no matter who you see, there's some level of training that people have received to provide all of the different interventions. In Navigate, what we have that's really different is that we really call it a specialty model. So everybody on the team has their specialty. And that is really, you're going to see that person for that specialty service. And we do that so that we have a group of experts on the team. So we're not really diffusing the treatment across the different team members. We really do have team members that are experts in each of these areas. Now, that does work a little similarly, where if somebody is not engaging with the IRT clinician, let's say, the IRT clinician can work in conjunction with somebody like the SEE specialist to provide some information and skills that they can do in that context. But really, they will be working together also to include or engage that IRT clinician so that, again, you're seeing the expert. The other big difference between Navigate and assertive community treatment is assertive community treatment was really designed as a hospital without walls. It was designed for people who really were having difficulty staying in the community, whether that was they were going in and out of the hospital, they just had an overwhelming amount of needs that couldn't be managed in traditional care. So it was really to help people live within their community, but continue to have these supports most of the time for the rest of their lives. Navigate was really created to reduce disability. So one of the things that we do that we don't do in Navigate, actually, is we don't automatically help somebody enroll in benefits. Because our goal is really to help them to return to full functioning, to return to work and school, and we want them to be able to enter the workforce if that's what they want, to enter educationally and develop a career if that's what they want. So that's not something we typically do because we want to reduce the amount of disability. And so we're really working from that model of taking people from that initial phase and helping them get back on track as soon as possible, rather than trying to help them stay out of the hospital and into the community and really not as focused on the disability part of things. So I hope that answers your question.
Great. Kristen asks, can you tell me more about how Navigate addresses substance use with FEP clients? I'm not sure how much you've touched on that already.
No, I haven't, and that's a good question. So specifically, I would encourage you to check out the Individual Resiliency Training Manual. So I believe it's Module 10 in there is all around substance use. Since the trial, we've actually made some changes because we learned a bit from how we're trying to address substance use, but we need to do a better job. So within IRT, we do some substance use assessment. So we try to get some ongoing information and continue with that throughout treatment about how much a person is using so that we can explore when they're ready, when they express some interest in cutting down or stopping or even suggesting some of that with them. We've actually even, some of the IRT clinicians are moving up some of those topics that are in Module 10 so that it's provided alongside the education about the illness. So the person would get information about psychosis and the symptoms of psychosis, and that would be followed about information about substance use and how that interacts with psychosis. So we've actually learned something from the trial, and we've and it changed up a little bit about how we do it, but we really try to, and we're trying to do a better job of addressing it alongside the psychosis, because we also know that there are extremely high rates in first episode psychosis of people who use marijuana and alcohol.
Okay, thank you. Another Christine says, this is wonderful info, thank you, which we love to hear, and asks, are there similar organizations for patients who frequently readmit to inpatient hospitalization, most commonly due to noncompliance of meds, or are there any groups that can be helpful after discharge?
Well, I think this really leads into the other question I was asked. So I think that if that's the person that you're working with, look into an assertive community treatment team. There's some resources at the state DHS that you can call on to find out how you could get connected to that. But that's what I would encourage you to do is if it's somebody who's had the illness for a longer period of time so that they wouldn't necessarily qualify for Navigate, I would be looking into an assertive community treatment team if they're really not able to engage in traditional outpatient services.
Thank you. Piper, would you mind putting up the slide with the website addresses, the navigateconsultants.org and the other one, please?
These are the two websites I didn't have on there. I can say it again, though. These are the two websites that have information about the 3 Navigate teams in Minnesota, so I will leave that up. And then the website where you can find all of the materials is Navigate Consultants with an S, so it's NAVIGATEConsultants.org.
Thank you. And we have one final question here. Kristen asks, does Navigate work with patients who are under civil commitment for mental illness?
It can. We have, I would say, fewer people that are under a commitment on Navigate programs, and that's likely because just the less experience with their symptoms, right? They've been sick a lot shorter amount of time, but many of our Navigate teams have actually worked with people who are on a commitment, so that should not deter you from referring somebody to a Navigate program.
Well, thank you very much. On behalf of the Minnesota Center for Chemical Mental Health, we'd like to thank our director, Dr. Piper Meyer-Kalos, for sharing her time and talents with us today. Of course, we'd like to thank all of you for joining us, and since this is the final broadcast of our free monthly webinar series for 2017, we'd like to wish you all a safe and happy holiday season. We hope to see you again January 12th. Thank you.
Thank you.